Thank you. Before I begin my presentation, I would like to thank the WFVS for the kind invitation. My name is Naoki Fujimura. I'll be presenting on behalf of JSVS. These are the disclosures. So background. So when I was studying Stanford, I was watching Dr. Jason D doing surgery every week. But in reality, in Japan, popliteal artery enteropathy syndrome is extremely rare. We only have 20 to 40 cases registered annually in National Clinical Database. I had a chance to do a retrospective study from 2003 to 2015. I asked around 50 to 60 hospitals, and I found only in 31 institutes and had 35 limbs, 28 patients. And we had excellent results because due to the number of limited patients, you couldn't answer this clinical question: which devascularization method is preferable for the popliteal artery syndrome? This is because there are many methods to the devascularization methods. There have been papers published about the long-term results of popliteal artery enteropathy syndrome, but this result is a mixture of these, variety of methods. So this is what we did. We did a multi-institutional retrospective study using JSVS registry, which runs on the National Clinical Database. All institutes that had cases registered as receiving surgical treatment for popliteal artery syndrome between January 2013 to December 2018 were asked voluntarily to participate, so it's not mandatory. So after consent to participate, an additional data collection sheet was created on Excel file and distributed. Then Excel files downloaded, filled, uploaded again, and we had to collect these data collection sheet. If there was a problem, we have to send them again and collect them again. So it's very cumbersome work, and it took a lot of time. So this is a summary of what we did. So in the beginning, we had 106 limbs, but in the end, we only had 58 de novo limbs. So due to the time, I'll skip through the statistical analysis, and this is the results. So as for the patient characteristics, it's a usual patient characteristics: young, male, dominantly male, without no comorbidities. But compared to the previous report, we had a very low frequency, low incidence of athletes and military, only 13% combined, which is different from the previous publication. As an initial symptom, we did have 3 patients that had rest pain. So these disease do progress. And we had only 2 patients had venous symptoms, and only 10 patients had neurologic symptom. And for the imaging model that was used for diagnosis, ABI CT scan was the most modality used. We only had 62% using duplex ultrasound, and during examination, we only had 22% using dorsal flexion during the examination. And we also had high prevalence of occlusion at 65%. This probably suggests that we have a delayed diagnosis of popliteal enteropathy syndrome in Japan. As for the classification, we used the Wheeler-Rich classification, and type 2 was dominant. This was similar to what's been reported, but we did not have any case of type 6, a functional popliteal artery enteropathy syndrome. So the first take-home message is type 2 popliteal enteropathy syndrome dominant. So it is similar to what's been reported, but without any type 6 syndrome. And we had frequent occlusion and less dorsal flexion during the examination, and this probably suggests delayed and misdiagnosis. As for the surgical treatment, we had 10 patients going medial approach, and others were posterior approach. As for myopathy, 75% of patients had some kind of myopathy. As for revascularization, only 7 patients had myopathy only, and other patients, 80%, 90% of patients had some kind of revascularization. 22 patients had bypasses, and I summarized these 3 procedures as in situ revascularization because you have to touch the local lesion, and they had 29 in situ revascularization. As for the postoperative complications, there were 6 complications, including 2 early occlusion. And modality used during follow-up of the AV and CT scan, and very less frequency of duplex ultrasound. And this is a primary patency. At 12 months, 92%, 3 years, 84%, 72% at 5 years. So not bad. Secondary patency is excellent, 93%. Again, freedom from clinical-driven TLR, it's good. And changes in Rutherford classification, as you can see, we had dramatic improvement. So I think we can say that the surgical treatment is effective for the popliteal arterial syndrome. But again, for the clinical question, which devasculation method is preferable for this disease? So after excluding 7 myopathy-only cases, we have 22 bypass surgery and 29 in situ devasculation. So I compared them, and this was the result. No difference for the primary patency, secondary patency, and also for freedom of target lesion devasculation. So this is my final takeaways. So excellent overall results. It means proper diagnosis, treatment is important. And no difference for the bypass surgery and in situ devasculation. So this is my conclusion. This I just suggest that because in Japan we don't have that much cases of this disease, and we don't have that much extreme meaning. We don't have that much experience doing this procedure. So considering complications like a nerve injury or you have to do surgical maneuvers in an inflammatory lesion, maybe bypass surgery may be simpler for those unexperienced hospitals. Thank you for your attention.